welcome all of you once again to our virtual classroom of ICA webinars to listen to the voice of the future. Today's topic is capnography. The word capnography comes from the word capinos, meaning smoke from the fire of metabolism. So we all know about oxygen and how to monitor oxygen. And I think the immediate answer which comes from postgraduates is pulse oximeter, SpO2. But we usually underrate carbon dioxide. Those who are closely monitoring the patient's immediate post-op, they'll realize that oxygenation might be seen normal, but patient may be accumulating carbon dioxide. So patient may become drowsy because of carbon dioxide accumulation, because you are underrating carbon dioxide metabolism, which is very vital for all living beings. In this diagram, you can find the pathway for oxygen. Okay, you can find it coming through the breathing system, getting into the alveoli, and it diffuses into the circulation, goes into the tissue, and at cellular level, the metabolism happens. Okay, the energy is released in the form of ATPs, but the byproduct is carbon dioxide. This carbon dioxide from the cellular metabolism, the carbon dioxide production goes into the tissue carbon dioxide diffusion, then it gets into the blood circulation for transport. It reaches the alveoli or respiratory membrane where gas exchange happens. And when we exhale, the carbon dioxide comes out. So this is where we catch it. When the carbon dioxide comes out of our respiratory system, we have gas analyzer modules detecting carbon dioxide, and then some will give only the numerical value, some will give the graphical tracing. So that's how capnography is going to help us, especially in the perioperative settings. Here we have a group of postgraduates joining us in this forum. I request the postgraduates for self-introduction in the order shown on the screen. Please.
Good evening, respected panelists. My name is Dr. Aditya. I'm currently doing my post-graduation in Maulana Azad Medical College.
Okay, welcome.
Good evening, respected panelists and everyone listening. My name is Dr. Deepak P. I'm doing my post-graduation at Government Medical College, Trivandrum in Kerala.
Okay, welcome, Deepak.
Good evening, everyone. Myself, Manas Omer. I'm doing my post-graduation from King George Medical University, Lucknow.
Welcome, Manas.
Good evening, everyone. I'm Dr. Prajwal Siddappa, doing my post-graduation in Kasturba Medical College, Bangalore.
Welcome, Prajwal. Dr. Richa. Please unmute.
Yeah, sorry, sir. Good evening, respected panelists. I'm Dr. Richa Tripathi, postgraduate student from Sir Gangaram Hospital, New Delhi.
Welcome, Dr. Richa.
Good evening, everyone. My name is Shreekara. I am doing my postgraduate residency from Maulana Azad Medical College.
Welcome, Dr. Sri.
Good evening, everyone. I am Dr. Vrinda from MES Medical College, Kerala, second year postgraduate.
Okay, so here we have a group of youngsters joining us who are pursuing post-graduation in anesthesiology to join us in the discussion all about capnography. Next week, we are going to have an ICA PG assembly session, case discussion, where Dr. Madhusudan Upadhyay from KMC Mangalore and Dr. R.P. Gadu, D.V. Patel Medical College, Navi Mumbai will be the examiners, and we'll have case discussions on thyroidectomy for thyrotoxic goiter and a short case discussion on diabetic food for amputation. Again, we have PG presenters, Dr. Ambika Khanna from St. John's Medical College, Bangalore, and Dr. Shreya Gupta from Maulana Azad Medical College, New Delhi, participating. So postgraduates, don't miss these sessions. These are going to be very useful for your exam preparation and your career ahead. So to start our discussion on all about capnography, I would like to invite Dr. Deepak for the topic introduction. Dr. Deepak, you can do screen share and introduce the concept. What is capnography, the terminology, and normal tracing. Please go ahead.
Thank you, sir. Good evening, everyone. Today, just now, as Dr. Saneesh has explained very well about the physiology behind capnography, I will be focusing more on the basics and the physics part of capnography. We'll be looking under the following headings, some terminologies, why it is important to do capnography, what is the technology behind it, what are the different types of monitors, and a little bit about the normal capnograms. This is actually quite a confusing part of this. Thing is, we have so many terms related to capnography. First of all, capnometry. Capnometry is the measurement and quantification of inhaled or exhaled carbon dioxide concentrations at the airway opening. That is, we are measuring and displaying a number. The measurement of that number is known as capnometry, and capnometer is a device that performs this measurement. Whereas capnography is the method of measurement and the graphical representation of this carbon dioxide concentration. That can be as a function of time or volume. A capnograph is a device that performs this measurement and gives the output as a graph. And the capnogram is the output or the graphical display that comes out of a capnograph. Why capnography? Just like Dr. Saneesh explained right now, carbon dioxide is a smoke of the fire of metabolism. That is, it provides information about metabolism, circulation, and respiration. When we actually measure carbon dioxide in the exhaled gas, it is an indicator that metabolism is happening, producing carbon dioxide. Circulation is good, taking that carbon dioxide from the tissues to the lungs. And also through the process of respiration, this carbon dioxide is diffused into the alveoli, and thus it is given out in the exhaled air. So if we are detecting carbon dioxide in the exhaled air, that means that all these steps in this process are working. Because of this, the American Society of Anesthesiologists guidelines of basic anesthesia monitoring has stated that whenever we introduce a tracheal tube or a supraglottic airway device, its correct positioning must be verified by identifying the end tidal carbon dioxide. And this carbon dioxide monitoring must continue throughout the procedure, either till the device is removed or till the patient is transferred to an ICU setup. And as an update to this particular basic standard, in 2005, an audible alarm was added to this monitoring standard. Here I have quoted a few studies. What each of the studies is showing is that nearly 50 or more than 50% of all critical events associated with airway manipulation in anesthesia were either priorly discovered or prevented due to correct monitoring of carbon dioxide. So with all these evidences and all this logic, can we finally summarize that carbon dioxide is the most important perioperative monitor? Hopefully we'll have an answer to that by the end of the session. So what is happening? Once we get a carbon dioxide sample, how do we detect the presence of carbon dioxide in the sample? There are so many technologies used for this. The most commonly used technique nowadays is the non-dispersive infrared analysis. What is happening here is that we are projecting a beam of infrared light through a gas sample. This gas sample is the exhaled air. When the light passes through this gas sample, the gases present in this gas sample absorb certain wavelengths of light. Here, for carbon dioxide, a wavelength of 4.26 micrometer is selectively absorbed. And when the remaining of this light is incident on a receptor, we can get an idea about what amount of light was absorbed. And the amount of light absorbed correlates with the proportion of carbon dioxide in the exhaled air. That is, if more amount of light was absorbed, that means more amount of carbon dioxide is present in the exhaled air. So what we need is a source for the infrared light. When we have an infrared light, then we can measure all the things. So we need a source for the infrared light. The most commonly and most easiest method is by emission through a black body radiation. A black body is a substance that, when heated, gives off infrared radiation. This infrared radiation is focused through a chopper disk. We'll understand that by the next diagrams. This is focused through a chopper disk to a sample cell with gas to be analyzed, and a reference cell with no detectable CO2. This is the image for this. Here we have a source of infrared light. This passes through a sample chamber. This sample chamber contains the gas to be measured. It passes through a chopper disc. This chopper disc makes sure that the gas alternatively passes through this sample chamber and a reference chamber. And this is finally incident upon the detector. And this detector gives an idea about the concentration of carbon dioxide in the sample chamber. This is another section of this analyzer. Here we see from this, the exhaled gases are coming into this sample chamber. The incident light, the IR radiations coming from here are passed through the chopper wheel, one through the reference chamber and the other one through the sample chamber. All this is incident upon the sensor, and we get an idea about the concentration of carbon dioxide in this sample chamber. This is actually what is happening inside a patient. Here, a sample of the circuit gases comes through this port. This, what we see, the round structure is the chopper wheel, and this is the IR light source. So in this whole unit, we are the gas is undergoing detection of the level of carbon dioxide. After that, this gas passes through the pathways, and then it is sent for multi-gas analysis. And finally, after analyzing for oxygen, it is pumped back. So this is pumped back either into the circuit or it passes through a scavenging system. That is one method. So in this graph, we can see a huge pyramidal structure. This huge pyramidal structure is the complete wavelength of infrared radiation radiated out by a black body radiation. The problem is that within this huge pyramid, there lies areas with absorption for carbon dioxide, for nitrous oxide, for anesthetic agents, and even for water vapor. So while using a black body radiation, the problem is that interference occurs with the presence of nitrous oxide, water vapor, etc. So an accurate measurement of carbon dioxide is more difficult, and therefore the need of a chopper disc and everything. For that, we have introduced a new system, that is the microstream technology. In microstream technology, it uses a laser-based technology to generate infrared emission that precisely matches. You can see the pink line here, a microbeam of infrared radiation that is exactly in the wavelength of carbon dioxide is incident upon the sample gas. And with that, we can get a much clearer idea without interference from nitrous oxide or any other anesthetic agents. This is the microstream technology. So that is the physics part of it, how the carbon dioxide is detected. So for all this to happen, in the sensor part, we have to have a part of the expired gases. This is achieved by sampling, and this sampling can be mainstream or side stream. In mainstream capnography, it is a non-diverting system where the sensor is placed within the circuit. Whereas in a side stream or diverting type of capnometer, the sensor is placed away from the circuit. So a sampling line takes the necessary gases through a line to the sensor, which is placed remotely to the circuit. First, we'll see about side stream or diverting type of capnography. Here, a diverting monitor uses a pump to aspirate gas from the sampling site through a tubing to the sensor that is in the main unit. Usually, we all use this. The tubing length of about 6 feet usually takes gases up to about 30 to 500 ml per minute. The problem is that when the whole of the minute ventilation or the whole of the ventilating volume is very low, as in case of neonates and infants, this uptake of gas is quite large. That is one problem. Also, while using low flow anesthesia, also the same problem occurs. And the gas we have taken contains all sorts of anesthetic gases. So we cannot just like that leave it into the atmosphere. Either we have to send it for scavenging or back into the circuit. So this is an image from Miller. This is what we usually see from the circuit. We take a sampling line, and through this tubing, it passes to the monitor where all these technologies are present to give us a reading. Here we get a capnographic waveform. One problem with side stream monitoring is that inside the circuit, all the expiratory gases contain carbon dioxide, water vapor, and everything is in the gaseous phase. Once we take it out through the tubing, once we take it out through the tubing, The water vapor inside this condenses and it can form as water, and the presence of water inside this analyzing part can be problematic. So that is one problem associated with side stream. Sorry. This is a graphical tracing of a side stream monitor. Here, when the green line shows the starting of ventilation. From the starting of ventilation to the 100% reading, we have a time delay. This time delay is known as delay time. So this graph is given so as to get three different definitions. First is delay time. Delay time is the time taken for this reading to start from a baseline to the 10% of its final value. Whereas rise time is the time taken for this graph to reach from 10% to 70% of its final value. The 70% in some textbook, like in Dorsch, it is given as 90%, but it's in Miller, it is as 70%. Either way, we can get an idea about the upsloping of the expiratory upstroke with rise time. And the total response time is delay time plus the rise time. So in side stream, because the gas has to travel through a tubing to the sensor, which is placed far away from the circuit, this delay time and rise time is pretty important. So we'll see the advantages and disadvantages of side stream monitors. First of all, side stream monitors can automatically be calibrated, and zeroing is automatically done. Because it does not add anything to the circuit, there is minimal dead space. There is very less chance of cross contamination, because for every patient, if we change the sample line, there is no chance of cross contamination. Also, as we saw in the image earlier, you can allow for multi-gas monitoring. And when we remove this sampling line from this, that port gives an access to the circuit through which we can administer bronchodilators and also use for remote techniques like MRI suits. Disadvantages is that any sort of water can lead to leak or obstruction, water secretions, etc. Also, for low flow anesthesia, a loss of gases from the circuit can be problematic. There is a problem with delay time. Also, increased number of disposables are required. That is especially problematic with patients with insurance. And also, air, if used for calibration, and if it is returned to the circuit in a patient undergoing low flow anesthesia, can lead to dilution of the gases. Next is the mainstream type of monitoring or non-diverting type. Here, the carbon dioxide is measured by the infrared technology and sensor is placed within the circuit. Here it is. This is also a picture from Miller. Here, this is the Y-piece and this is the patient end, and the whole of the sensor unit is present within the circuit itself. So from here, a cable takes the data and the waveform is present on a faraway monitor. Biggest advantage here is that because the sensor is within the circuit itself, there is no delay time present. Advantages: no delay time, therefore faster response. No loss of gases, and as the gases are not being taken out of the circuit, the heat is preserved, there is no condensation and decreased chance for equipment failure. Pure use of disposables. Disadvantage is that it adds to the dead space, it adds to the weight of the circuit, increased drag on the tracheal tube, chance for accidental extubation. Also, mainstream monitors are used usually for the analysis of carbon dioxide and oxygen only. And because the same equipment has been used for different patients, potential for cross-contamination is present. This, as we told, that this monitor is heated up to a temperature of 40 degrees Celsius. When it is placed on the patient's face, it can be a chance for facial burns. And also because of the weight of this monitor, it can be a chance for pressure sores on the face. Several international and US guidelines have set certain standard requirements. That is, carbon dioxide reading shall be within 12% of the actual value. The manufacturer should disclose any interference caused by other chemicals. It should have a high carbon dioxide alarm and a low carbon dioxide alarm. So this is a multi-para monitor that we see every day. In this, we have the ECG tracing, the plethysmography tracing, and the carbon dioxide tracing. In this carbon dioxide tracing, if this is the one, we are looking at three different things. Firstly, a value, a numerical value, which corresponds to the end tidal carbon dioxide, a waveform, which is known as the capnogram, and over a large number of breaths, the carbon dioxide trend. This is many such capnographic waveforms for close together so as to give us a trend of the EtCO2 of over many breaths. So we'll see about capnograms. What was capnogram? Capnogram is a graphical representation of carbon dioxide concentrations in the exhaled air. So it can be of two types. In both these, on the x-axis and the y-axis, we have two axes. As it is showing the concentration of carbon dioxide on both the y-axis, it will always be carbon dioxide. Based upon what is there on the x-axis, we have a time capnogram, where on the x-axis we have time, and a volume capnogram, where on the x-axis we have the exhaled tidal volume. First, a normal time capnogram. Actually, time capnogram, it is divided into 4 phases, and this 4 phases has been defined by different authors in different ways. I am sticking to what Miller has said. According to what Miller has said, there are 4 phases. Phase 1 is the starting of expiration, which corresponds to the exhalation of dead space gases from the central conducting airways. Phase 2 is the transitional phase, where we have all the gases till the respiratory bronchioles. Phase 3 is what is composed of the alveolar gases. All the gases in the alveoli comprise of the phase 3, which is a plateau. If a patient has a homogeneously ventilated alveoli, that is, all the alveoli are normally ventilated and normally perfused, there is no disease condition, all the alveoli will be opening simultaneously, and the end-tidal carbon dioxide, or the phase 3 of this capnogram, will be flat as a plateau. With changes in the ventilation and perfusion, the slope of this phase 3 can increase. Increased slope of phase 3 denotes a ventilation perfusion mismatch. And a phase 4 or a phase 0, in Miller it is phase 0, denotes a sharp decline in the carbon dioxide, whereas where the inspiration begins. And inspiration is also included in this phase 0. In Dorsch, it is like phase 4. So we have 4 phases: an initial starting, where we have dead space gases coming out, then expiratory upstroke, where there is transitional airways up to the respiratory bronchioles, a phase 3 or a plateau phase, where the alveolar gases are shown, and a phase 0 or phase 4, where there is a rapid downstroke and inspiration. There are 2 angles which is of importance: alpha angle and beta angle. Alpha angle is the angle between phase 2 and phase 3, and beta angle is the angle between phase 3 and phase 0. Alpha angle is normally 100 to 110 degrees, and beta is normally 90 degrees. With the change in alpha and beta angle, variety of pathology conditions, which we will be discussing down the line, can be explained. Then the idea of EtCO2, or end-tidal carbon dioxide. We always know this value. So usually, most commonly, what is EtCO2 is the last volume, or the PCO2 value just before inspiration. It can also be the largest PCO2 value during a single exhalation, or for cases where it is a flat part 3, it can be the PCO2 value at a specified time in a capnogram, averaging across several breaths. For a normal patient with a homogeneous ventilation and normal perfusion of the alveoli, the EtCO2 and PaCO2, or the arterial carbon dioxide, is usually quite close to each other, with a difference of less than 5 millimeters of mercury. We saw about the time capnogram. Here we are going to see about the volume capnogram. Here,
Deepak, sorry to interrupt. We'll take up volume capnograph later.
Okay, sir.
We'll finish with the time capnogram, and then we'll come back to volume capnogram.
Okay, sir. I'll stop my screen share now, sir.
Okay, thank you very much for the excellent, crisp introduction of the topic. I think the science part is already done. Okay, I think for the audience also, we are happy to start receiving the audience query. Already there is a query regarding EtCO2, whether it is reliable in one lung ventilation thoracotomy. Basically, this is a non-invasive measure which is very close to partial pressure of carbon dioxide, arterial PCO2. It's already mentioned that normal EtCO2 to PaCO2 differences are going to be 2 to 5, but it all depends on the sampling. In one lung ventilation, definitely the sampling is different, because only one lung is getting ventilated And even for thoracotomy, the V by Q mismatch is there, the pressure difference is there, the ventilation mechanics are different. So our end-tidal CO2 sampling may not be accurate. So in those situations, I think we have to go on arterial blood gas to check the carbon dioxide status. So now we are doing youngsters interactive part. Okay, as Dr. Deepak has mentioned, before you try to interpret EtCO2 or capnogram tracing, we need to look into three things: capnogram, a running waveform, the end-tidal CO2, and the CO2 trend. Definitely perioperative monitoring, we surely look into all these three factors, but most of the scenarios which I'll be showing, sometimes you will get to interpret only from the waveform, the capnogram only. So this is already explained, the normal capnogram. Can somebody let me know, like when alpha angle increases? Alpha angle is normally 100 to 110 degrees. So it is decreased in which condition and increased in which condition? Anybody volunteering? Okay, so then we'll go to the capnogram scenarios and then discuss there. Okay, so who is going to identify this for me? The equipment shown here. We'll start in alphabetical order. Dr. Aditya, you have seen this equipment?
Yes, sir. So is this a capnometer?
Capnometer, because it gives only the value. It's not giving the tracing, and the equipment is called as capnometer. Okay, fine. This is Emma CapnoCheck mainstream capnometer. Okay, who is going to attempt this? What is the significance? Anybody, you can volunteer. Yeah, Dr. Manas.
It's a calorimeter. Like
Okay. So
sir,
how does it work? How does it
sir,
work?
it senses the carbonic acid released from the body. Like the CO2, it changes the color as per purple and other colors.
Okay, the color indicator is already mentioned in the device itself. So here you can see 0.5 to 2 to 2 to 5. So when carbon dioxide level comes to 5%, okay, the unit is different. 5%, the color changes to yellow. Okay, so after your endotracheal intubation, you can connect this device. If it is changing to color denoting presence of carbon dioxide consistently, then you are more sure about the positioning of the endotracheal tube, right? Okay, but there are some disadvantages. This is all not always reliable. Sometimes the color change may not revert back, or you may be misguised by the color change, which might occur permanently, because if it is already changed to yellow, even if you put an endotracheal tube in the esophagus, you connect it, you'll be surprised that it's yellow. So there are some literature evidence to such incidents as well. Okay, so this is another equipment. If you see, you can see the connector part is different. Where is it used? Where is it used? This is again working on the same principle, detection of carbon dioxide with the color change, colorimetric method.
So is this used for PCT, percutaneous tracheostomy sets?
No. So every time you put a Riles tube, nasogastric tube for feeding, there is especially sick patients, your auscultation may not always be confirmatory. So this is one method to check whether CO2 is coming out through the tube. Okay, so this connector is actually tailor-made for Riles tubes. Okay, this is just for information. Okay, equipment is called CO2 confirm. Okay. So this is going to be a very simple question. Identify me the one on the left side A and one on the right side. I don't ask Dr. Deepak. Dr. Prajwal, your first go. Dr. Prajwal.
A is mainstream capnography and B is side stream.
Okay. Have you seen mainstream being used?
Yes, sir, in ICU setups.
Okay, excellent. Why do you want to use mainstream in ICU?
Usually there won't be any time lag, sir, and instantaneous values.
That is there. Anyway, we'll be discussing the role of capnography in ICU because it actually gives you the trend of CO2. May not give you an exact correlated value for your arterial PCO2, but
Yes.
it can definitely give you trend so that you can monitor the minute ventilation on different parameters. You can reduce the number of invasive blood gas investigations. Okay, that's the advantage of using capnography in ICU. Okay, this is mainstream. The one on the right B is side stream, which is very common. So now next one is look at this monitor very closely and comment on the end tidal CO2 value. A new person, please, who has not appeared on screen. Yes, go ahead. Dr. Richa.
Sir, this is a normal value of EtCO2. It's in kilopascals. Normal EtCO value in kilopascals is 4.5 to 6.1.
Yes. So that's the message from this. So you don't just check for a EtCO2 of around 35 to 40 every time. Do look at this unit nearby because our monitors are equipped to give values in millimeters of mercury as well as kilopascal and percentage. Okay. If you watch this video closely, I can change the unit from here percentage to millimeters of mercury. Now we are familiar 37 familiar range of digital values for EtCO2 comes. So when you go for abroad exams, sometimes ABG also you might get in kilopascals and all. So you need to be familiar with the values, the units, and probably the conversion values. This is very important. Okay. So the message is before you start interpreting EtCO2, look at the digit, look at the unit also. Definitely, we'll be looking into the trend, the shape of the capnograph along with this value. Okay. Usually in between, if somebody comes into your operating room, suddenly finds EtCO2 of 44, definitely the consultant will be asking, no, why EtCO2 is 44? So just look at the trend and see whether it's abrupt increase or it has been increasing over a period of time. Okay, so actually this is the first set of questions. So far we had gone through some primers. So who would like to take this scenario? We have around 15 to 20 scenarios. Yeah, we'll start with Dr. Manas.
So it's a curare notch. It shows a spontaneous ventilation. Spontaneous ventilation. The
Okay.
1/3 part of the expiratory phase shows spontaneous respiration, and then it goes. Either we have given muscle relaxant, so it has gone back to the normal value, normal waveform.
Or it may not be very consistent also because
Yes,
spontaneous attempts may be at a lower rate also when
yes.
patient is about to come out of the neuromuscular blockade. So indirectly, you can always say that EtCO2 tracing is also a neuromuscular monitor. Okay. In that sense, we'll also describe about our reservoir bag as one of the neuromuscular monitors, right? So again, we are actually looking at the spontaneous breathing efforts in addition to the mechanical ventilation that we are providing through the ventilator. Okay. So where do you get these scenarios? When patient attempts to take breath? Okay. It can also be seen in patients with cervical transverse lesions because of the diaphragmatic palsy and different diaphragmatic movements. It can be seen in flail chest, can be seen when patient has hiccups, and in cases of pneumothorax also, you might get similar tracing even if the patient is under neuromuscular blockade. So we need to keep this in mind. That's what I said, depending on the condition, interpretation changes. So it may not be always due to patient taking spontaneous breaths, but classically we describe it as curare notch. Okay, fine. So scenario number 2, Dr. Deepak.
Sir,
You have
this was
pride of
these are
opportunity.
cardiac oscillations.
Yeah, okay, fine. So these are the cardiac oscillations. So don't confuse it with the breathing attempts. Okay, fine, correct. So what is the mechanism behind these cardiogenic oscillations?
This is occurring when the heart beats against such as most commonly seen in children, because size of the heart is relatively large in comparison to the tidal volume.
Okay.
So when it beats along with the chest, it.
Okay, so it can have its own repercussions in the exhaled gas composition, and it can push in gas intermittently, causing in rhythm with your ECG rhythm. Okay, that is one way of checking it. So it may not be like a multiple Curare effect kind of thing. If it is matching with the ECG rhythm or heartbeat rhythm, it is cardiogenic oscillation. So these are the factors: negative intrathoracic pressure, a low respiratory rate, diminution of vital capacity is to heart size ratio, as Dr. Deepak has mentioned. A low IA ratio also, you can get cardiogenic oscillations, and when you are ventilating with the low tidal volumes. Okay. It is more of a rule rather than exception in case of pediatric patients, especially neonates and infants. So which is very commonly seen. Okay, fine. So this is a very simple scenario. Who would like to take? Dr. Vrinda?
Sir, this capnography represents the prolonged expiratory phase that indicate bronchospasm.
Okay. So which is this phase? Dr. Deepak has mentioned, no?
This is phase 3.
Phase 3. Okay. So basically you can name it as upsloping phase 3. Okay. Why should it have upsloping? Why we are not getting a horizontal alveolar plateau?
This is due to the heterogeneity of ventilation perfusion.
Yes, exactly. Even in normal conditions, V/Q ratio is not 1. Okay, it varies across different zones. So average V/Q ratio is 0.8. So the expelling of carbon dioxide from different lung units or alveolar units happen at different paces. That's why even normally we get slightly upsloping phase 3, which we consider that as normal. But when it comes to scenarios like acute bronchospasm, the initial low V/Q areas or high resistance areas will release carbon dioxide later. So actually the carbon dioxide values towards the end of expiration picks up pace. Initially, because of the expiratory flow limitation, less of carbon dioxide is released. The alveolar carbon dioxide release is less. So the capnography tracing starts very low, and as it progresses, it empties more carbon dioxide. This is what we were referring to, the alpha angle. Alpha angle, normal, we have mentioned it is 100 to 110. So now the angle has increased. Okay. So depending on the slope, we can make out how much in airway expiratory flow resistance is happening. But bronchospasm is not the only cause. What else can cause it?
ARDS?
No. Any expiratory flow limitation like kinking of endotracheal tube or circuit kinking, even apart from the bronchospasm elements, there are other causes also. So whenever there is an expiratory flow limitation, the carbon dioxide release is going to be affected. So what are you going to do? If suppose there is a laparotomy going on and suddenly you find upsloping of phase 3.
First of all, I have to rule out the causes of bronchospasm. There are we have respiratory as well as mechanical and also the drugs. Respiratory, when we consider, it can be upper respiratory tract or lower respiratory tract. And in upper respiratory tract, it can be due to any foreign body in obstructions and laryngospasm, and or in lower respiratory.
Extubated patient. Okay, or when you are monitoring with laryngeal mask airway. Okay, fine.
In lower respiratory tract, it can be due to COPD.
So, how do you differentiate these things? Practically, how do you differentiate? Because there is a list of some 8 to 10 causes of upsloping phase 3. What do you do immediately? Just because there is a upsloping, you don't start a nebulization or give a shot of steroid, right? So first exclude the mechanical causes. Okay, tube kinking and all. Then look into the clinical signs of whether there is any rhonchi.
Okay.
Especially if you are anticipating it because it's a bronchial asthma patient or patient has a history of allergy or a risk of anaphylaxis. So immediately check, auscultate, and then you will come to know where you have to intervene. Okay, if it is a tube kinking, simple, release the tube. If it is in ICU, it's a tube obstruction with secretions, do a good endotracheal tube suctioning, maybe nebulization with water so that you can hydrate the secretions and remove it. That's it. Okay, if it is a bronchospasm per se, either troubleshoot the bronchospasm reason. First, the lighter plane of anesthesia. So increase the depth of anesthesia, maybe increase your volatile agent or give a additional dose of propofol or increase your dexmed or additional dose of opioid or whatever. And then try to go for the bronchodilators. Of course, steroids are always in considerations. Okay, this is what we regularly do, right? And the good thing about ATCO2 is as and when our maneuvers work, the upsloping also should disappear. Okay, it can even be due to a pneumothorax which you may have missed. So no point continuing with nebulization. So clinical method, if you have an ultrasound in the OT, if you suspect pneumothorax, go check the lung ultrasound and do the intervention. Okay, that's the beauty of capnograph tracing. Okay, not going into the differential diagnosis. Yeah. Scenario number 4, who wants to take? It's not very straightforward because so far we have been discussing EtCO2 going up and going up to the end tidal CO2 value and dropping. Here we don't see it at all. This is the problem area, right? So who wants to attempt? Yeah, Dr. Richa.
Sir, contamination of the sampling line.
Yes, contamination or a leak in the sampling line so that when carbon dioxide is actually getting exhaled, then at the later part of the expiratory phase, it is getting leaked outside the sampling. Okay, so it can happen sampling size too near the fresh gas inlet because the fresh gas inlet keeps on diluting the CO2 values. It could be a leak or too high a sampling flow rate can also cause issues with the sampling. Okay, I mentioned in the beginning, only if the sampling is good enough, we can have a reflection of the PCO2 level. So check your connections immediately before you venture into other troubleshooting. Okay. Yes, this is again a similar one. Yeah, Dr. Manas or Dr. Aditya. Yeah, sorry.
So it's a sampling line leak.
Okay, again,
So
it's another manifestation of the sampling line leak, which we can easily recognize and do something about, right? So This is characteristically described as an upswing at the end of phase 3. Upswing at the end of phase 3, usually seen in obese patients during pregnancy. The height of the plateau is inversely proportional to the height of the leak. Okay, so brief peak is usually caused by the next inspiration. So when the positive pressure transiently pushes the undiluted end-tidal gas through the sampling line. So all because of the leak in the sample line, especially in the side stream. So mainstream capnography, we don't get to see this tracing. So this is another classic one. You can see the reverse shark fin appearance, which is classically described. This I have taken from my OT. So once you seal the leak or check the gas sampling line, then the EtCO2 tracing simply returns to normal immediately. Okay, scenario 5. Dr. Deepak? Yes. Yes, Dr. Deepak, please.
So this is an increase in the rise in baseline, probably due to rebreathing of carbon dioxide.
Okay, there. This is very important. So far, we have seen traces where baseline is 0. So during inspiration, it's not coming up to 0. Then why you didn't comment on this value? Because this is overshooting our high alert mark.
So that is due to the increased baseline.
Yes, yes. Because the baseline itself is shifted up, your EtCO2 also will be correspondingly showing higher values. So rebreathing, usually when you get exhausted absorbent, especially on the first day of the week, right? So we feel that soda lime color is okay, and in the first case, you will find out that all of a sudden we get this value, FiCO2, right? So what is the FiCO2 cutoff before changing the soda lime canister? Just because you see a FiCO2 of 2 or 3, are you going to change? Or what intervention would you like to do?
Increase the flows, sir.
Increase the flows, yes. Okay, how does it work? When you increase the flow, how does the rebreathing reduce?
When we increase the flows, there is like if we increase the flows to more than the minute ventilation, the whole of the volume within the circuit is flushed off after every breath. So rebreathing of carbon dioxide can be minimized because fresh flows are coming for each breath.
Yeah. So basically, you are eliminating the role of soda lime canister as such. The idea of going to the low flow is we are trying to use the maximum of rebreathed gas mixture into our fresh gas mixture after removing carbon dioxide. Carbon dioxide is the only element you would like to remove before making it join the fresh gas flow. So, but if you are going to low flow or minimal flow, definitely you have to use maximum of rebreathed or exhaled gas mixture, and you have to eliminate carbon dioxide at the maximum. Okay, if you are increasing the fresh gas flow, probably some of the carbon dioxide will be exhausted through your APL valve, exhaust valve. That's when you get reduced rebreathing. And if all the carbon dioxide, exhaled carbon dioxide gets exhausted through the APL valve, then soda lime itself can be, the role is minimal. Okay, so that's not the point. So transiently, you try to increase the fresh gas flows and then see if soda lime canister change is required. Some of the machines, once you remove the soda lime canister, the circuit is open and you get a huge leak. And some of the modern machines, when the moment you release the soda lime canister, the circuit is sealed, it will run on its own. Okay, so you have to know your machine before attempting all these things. But definitely before the start of the case, you have to check for the soda lime exhaustion. Okay, incompetent expiratory valve is another cause which can cause recirculation of the exhaled gas, insufficient fresh gas flow to a Mapleson system, as we mentioned here. So there is again a chance of rebreathing and problems with the inner tube of the veins system. Of course, definitely examiner's favorite question. Unacceptable FiCO2, definitely when the value goes to around 4 to 5, you have to change. the soda lime canister or go to high flows. Okay, this is something that we have discussed. Who would like to go through this? Yeah, actually, we are getting good response from the audience too. Yes, great. So thanks to the audience who are putting your comments. You can keep on putting the comments. Okay, fine. Dr. Sri?
This is return of spontaneous circulation.
Okay. So why in the initial part, it's very slow, dull, and then it gradually improves?
Sir, after successful CPR, the patient circulation will improve.
This is
based
not
on which the
this is a post-operative extubation scenario.
Initially the
reverse the neuromuscular blockade.
Initially the smaller tidal volumes is taken spontaneously.
So as the patient gets released from the neuromuscular blockade, his muscle power improves. Gradually, his tidal volume improves. His alveolar ventilation improves. So after some time, when the breathing efforts are adequate, now our sampling is good enough to reflect his PCO2. Okay, fine. So that's when after our adequate reversal, the tracing goes to a, even the area under the capnography improves. That means the adequate alveolar ventilation is happening. And then you can continue monitoring the neuromuscular recovery, or you can consider extubation. Okay. So just because you find one or two tracing like this, you don't try to extubate, because some patients, the time between our reversal administration and the adequate recovery might differ, especially if you are not monitoring the neuromuscular junction very closely. Okay, so this is the case of return to spontaneous ventilation. So first breath is typically small volume, subsequent breaths show progressively higher peaks, gradual resumption of normal waveform. This is again, we are monitoring reversal of neuromuscular blockade with the help of capnography. Okay, fine. 7. This tracing is slightly different from what we have discussed so far. Yeah, Dr. Aditya.
So this is seen with an incompetent inspiratory valve.
Okay.
In our breathing systems. So
actually,
the patient's
should have been like
inspiration,
this, right? Should have been like this. When the inspiration starts, the carbon dioxide should have been diluted, and it should have reached the baseline right here. Because of this, there is gradual dilution is happening, and slanting inspiratory downstroke. Inspiratory phase is shortened. So it may or may not reach 0. Okay. Incompetent inspiratory valve. It's correct. Okay. Especially in a scenario where suction is applied to the chest tube also, you will get tracing like this. If you are following the tracing in our ICU, or you take this sick patient for a surgical procedure inside the operating room. So whenever you get an ETCO2 scenario like this, probably with your mobile phone, you take a snap, keep it with you. Okay, that adds on to your experience. Experience counts, right? Okay, fine. So, simple scenario. We are getting, you can note that it is given in percentage, 5. So forget about that. Maybe the 5 mark is 40 millimeters of mercury. So you get 2 good tracing, all of a sudden, nothing. So, Dr. Sri, Dr. Shreekara?
Maybe disconnection in the circuit, sir.
Pardon?
Disconnection in the circuit.
Yeah, immediately you think about a disconnection in the circuit. That is one thing. Anything else? Anything else can cause a sudden drop to 0.
Pulmonary embolism.
Yes, sudden cardiac arrest, pulmonary embolism, but it may not happen like this all of a sudden. Very next breath, it may not drop to 0. That's a point in favor of your disconnection theory. Okay, agreed. Correct. Anything else to add from our PG panelists? Ventilator disconnection or totally obstructed ET. So you look at the
Misplacement of tube.
Pardon?
The misplacement of tube gets
Yes, yes. Or misplacement or complete obstruction of the endotracheal tube. The airway.
Ventilator turning off, sir.
Yeah.
Ventilator turning off.
Ventilator turning off. Exactly. Yeah. Or your gas sampling line is disconnected. Okay. Or you need to consider cardiac arrest also. But usually you get pulse oximeter, tracing, ECGs, and other monitors. So ETCOT is not the only monitor you are going to rely on. But definitely when you see a tracing like this, you need to have an immediate action. Okay, immediate troubleshoot. If you want to stop the surgeon, it's fine. You can intimate the surgeon, say you have a problem at hand, then you go ahead troubleshooting. Okay. So, Dr. Prajwal, this is what we have been discussing. This is a trend graph. Trend graph of ETCO2. You can see the trend gradually falling, but not to zero. So what could be the possibility?
Embolus, sir.
Yes. Yeah, that's what we've been discussing.
Gradual fall in the ETCO.
Gradual fall. Okay. So it can also happen with poorly fitting tracheal tube or mask. Okay, suddenly the cuff is released or cuff bursts or your LMA gets displaced. Previously, we had discussed complete obstruction. Here, a partial obstruction or disconnection of the breathing system, partial obstruction of the tracheal tube, sudden hypotension. Okay, ETCO2 tracing is also an indirect measure of the cardiac output also. Unless the cardiac output goes to the lungs delivering the carbon dioxide won't be exhaled, right? So sudden hypotension or sudden cardiogenic or shock scenarios, or definitely pulmonary embolism can also cause this scenario. When the ETCO2 value comes below 10, 15 or less than 20, you need to take immediate steps. Okay, so immediate attention is needed. So this trend tracing is very important. Who would like to interpret this? Yeah, Dr. Richa. Your microphone is mute mode. Yeah.
So patient is making an effort to breathe in between two breaths.
Why this wavy form in the affected plateau?
The plateau is not.
It's not a plateau. Even the inspiratory part is not plateauing. Dr. Vrinda, any
sampling?
Tube is it's accidental going out.
Yeah, sampling error. Because the cuff is leaking, or surgeon is doing some manipulation in the chest, compression on the thorax, which can cause different rates of expulsion of carbon dioxide, pressure on the chest, or a displacement of tracheal tube, which is very common because sometimes especially in pediatrics, the tube going in, maybe uncuffed tube going into the glottis. If tube partially comes at the level of glottis or just above the glottis, you may not get a perfect capnograph tracing. So whenever you get a wavy plateaus like this, you need to do the troubleshooting. Okay. The idea of monitoring is you don't want a sudden cardiac arrest, because sudden cardiac arrest or collapse usually follows a trend. The moment you pick up the trend, you can avoid that catastrophe. That's what Dr. Deepak mentioned in the previous literature. The majority of airway hazards and many of the perioperative complications can be avoided if once we pick the clues from our monitoring. This is enjoyable for our audience. We have been discussing about some of the scenarios of capnography. So we don't forget the audience watching us over the web page of ClearNet. So this is the audience question. This is the trend graph of CO2. So I'm not going to describe this further. It's your chance. You can text in your answer. We'll discuss after a while. I hope the scenario is clear. I think whichever response I get, it comes with your name also. So we'll see how many of you get it correct, because this is a day-to-day scenario. We'll see that. Okay, now Dr. Deepak, you have been silent for some time. Say, comment on this. Capnography tracing obtained during CPR after definitive airway insertion of a 70-year-old gentleman who collapsed with chest pain in ICU. Comment on the quality of chest compressions. Explain the possible event marked with an arrow mark.
Sir, according to this tracing, the quality of CPR is good, because for a normal CPR, about 1/4 of the normal ETCO2 value is what is aimed at. That is, by CPR, we are attempting to give 1/4 of the normal cardiac output. And from the arrow, we see at that point, there is a return to spontaneous ventilation. We can see that when there is a rise of more than 10 millimeters of mercury from the previous values, it is 97% sensitive for ROS, or return to spontaneous ventilation.
Okay, excellent. Okay, so nowadays we have been stressing on the role of capnography in ACLS, because American Heart Association and all the resuscitation guidelines connected to ILCOR, they recommend confirming definitive airway placement with use of capnography. So we are not speaking about scenarios inside the theater. Even pre-hospital, most of our ambulances are getting equipped with capnography, especially our accident emergency department definitely should be equipped with capnography tracing, one to confirm definitive airway. The moment you decide to go ahead with a definitive airway during a cardiac arrest scenario, it is a great decision, but it should not harm the patient. The moment you put a definitive airway, it should be in place. You cannot put an endotracheal tube into the esophagus just because you are in a hurry and continue with the ACLS guidelines. You won't revive the patient. So confirmation of definitive airway is required. And because you want to continue higher chest compression fraction, most of the ACLS scenarios, even supraglottic airway should be good enough to maintain airway as a definitive airway. But capnography is ensuring good quality, and these are the advantages. I'll quickly go through that. I think we'll come to this point a little later as well. Loss of ETCO2 may be the first sign that CPR is needed or patient is going into cardiac arrest. The compression feedback devices measure CPR quality. ETCO2 measures how the body responds to it. Waveform capnography guides ventilation rates and confirms airway placement, advanced airway. Capnography helps to determine when to terminate resuscitation or when to continue the effort. A spike in ETCO2, as Dr. Deepak has mentioned, reading is the first sign of return of spontaneous circulation, and a drop in ETCO2 may be the first sign that it is lost. Okay. So scenario number 13. Explain the inferences from the tracing scene in a laparotomy for 35-year-old lady with duodenal perforation undergoing general anesthesia with endotracheal tube IPPV, given that minute ventilation is maintained stable. Who would like to take? Dr. Aditya, would you like to comment on it? Your laparotomy patient. This is the
So this could mean that there's a uncontrolled bleeding, hypovolemia, or something that would cause a decrease in cardiac output as the patient's CO2, despite a stable minute ventilation, has decreased.
Yes, exactly. Fine. So a rapid fall in ETCO2 over a period of several breaths can happen when there is a sudden drop in the cardiac output. Okay, so you need to check the surgical field, you need to check the surgical drain, or other possibilities also. A decrease in metabolism, hypothermia, pulmonary embolism. You need to troubleshoot this depending on the history and the trend so far. But these are the possible things. Okay, next one. We are slightly running behind schedule. So 2 tracings. Who wants to take? Yeah, Dr. Richa. Your microphone is on mute mode.
Insert scenario A, the patient is hyperventilating, ETCO2 is lower than 30. It also may be due to a venous embolism during or a sclerotherapy or something. There is a small drop in the ETCO2. Insert scenario B, the patient is probably hypoventilating. The ETCO2 has risen above the normal values.
Okay, fine. So there is 2 contrasting scenarios. One where ETCO2 trend has gone down, and the second scenario where trend wise, value wise, it is going up. So these are the situations where hyperventilation is done, and we need to be aware about the potential side effects associated with hyperventilation. It's not always good. Okay, hyperventilating means you are ventilating against probably a sick lung. So ventilation-induced lung injury, RV dysfunction, reduced cardiac output because it's positive pressure ventilation, MI, cardiac arrhythmias, all lots of list. I'm not going to go through the list. And if you look at the CNS part, it can cause cerebral vasoconstriction, reduce CBF, and I'll show the slide. It can even cause reduced, increased neuronal excitability and reduce epileptic threshold if you hyperventilate too much. So traumatic brain injury do not equate with hyperventilation. So that is one message I would like to give here. So there are some disadvantages of prolonged hyperventilation because it will cause vasoconstriction leading to reduced coronary and cerebral blood flow. Unnecessary respiratory alkalosis will be produced, depression of respiratory center. And in traumatic brain injury, what happens is, this is the famous trend chart, the impact of PaCO2 against cerebral blood flow. It is shown in the green tracing. Not going to explain much about it. So hyperventilation is not indicated on a blanket rule. If there is intracranial hypertension, yes, but not too much hyperventilation. Maybe 30 to 35 ETCO2 should be good enough. Or if you want to look at the blood gas values, you target only that in the initial phase and then try to do the other measures to reduce the intracranial hypertension. So in the next day also, unless there is intracranial hypertension, there is no role for hyperventilation and maintaining a low PCO2, which is actually detrimental in a patient with a neurological injury. So hypercapnia or hyperventilation is in the other extreme. It can also contribute to negative cardiopulmonary impacts, and it can lead to hypercapnia and raised ICP also. So either way, it's not required. But we'll discuss towards managing ETCO2 trend in the ICU patient, because sick patients, it's a different ball game, and you need to be more vigilant about controlling your ETCO2 values. So we'll move ahead with the next scenario. Who wants to take this? Any volunteers? Yeah, Dr. Richa? Yes. Yeah, microphone is mute again.
Sir, pneumothorax.
No,
Bulla rupture.
Capnography tracing. 72-year-old chronic smoker, bilateral equal air entry, intensity of breath sounds reduced bilaterally. Clinical impression, differential diagnosis.
So bulla rupture in a COPD patient. Bronchospasm.
A downsloping phase 3. Dr. Prajwal, any comments on this?
Reverse shark fin can be due to sample line blockage only, sir. But reduced breath sounds are there. We have to rule out bronchospasm also.
Okay. Okay. So COPD or emphysema is one of the causes. Okay. So there will be marked destruction of the alveolar capillary membranes. So what it causes is reduced gas exchange. So eventually the waveform will lean in the wrong direction. So what you do immediately is to look for the complications of emphysema. And then if you have a suspicion of a pneumothorax, you can look for that. Or if you can have a lung ultrasound, do a lung ultrasound and check for this bullae rupture and all. And then if you can constitute a bronchodilator therapy, you can relieve the expiratory flow limitation, and your the slope of phase 3 can be leaning more towards normal direction. Okay. Definitely, as Dr. Richa has mentioned, patients with pneumothorax, they won't be able to maintain the plateau in phase 3. The shape will start high and then tail off as air leaks from the other side, from the lung, producing a similar and like high on the left and lower on the right shape. So curve leaning towards the wrong side. Diagnosis is differential diagnosis. Immediately what should come to mind is emphysema and its complications like pneumothorax. Okay, nice. Yes. I think you would have come across this scenario. We have already discussed about the rise in the baseline. Okay. 32-year-old lady, lab sterilization under general anesthesia, hemodynamically stable. After reducing fresh gas flow to less than 1 liter per minute, this is what happening. So what do you do next? I think Dr. Deepak has mentioned already. First, you increase the fresh gas. Okay. Check whether soda lime canister needs to be changed. Okay. FiCO2 6 means definitely you have to change the soda lime canister. In ICU, such a thing is unknown. It will be very surprising because ICU ventilation, there is no rebreathing issue. Okay. Only inside OT, we are recirculating the exhale gas. This, I think we have already described laparoscopic cholecystectomy, sudden disappearance of EtCO2 tracing. Look for the mechanical causes, disconnection, endotracheal tube function. And this is again a shark fin appearance. So we'll move forward from that. Okay. So what is this? This is a chocolate question. Who wants to get it? Yeah, go ahead.
So tail fin pattern in EtCO2 may be seen in pregnant or obese patients.
Okay. Classically known as pigtail capnogram. Okay. Typically seen in poor lung compliance, pregnancy and obese. Okay. Agreed. So essentially sudden peak of pre-inspiratory expired CO2 is due to sudden airway closure, as it happens in obesity. It occurs in poorly compliant lung. It crushes the last few milliliters of CO2-rich gas from the alveoli before collapse of the lung parenchyma. Okay, that's how you get a slight upstroke, pigtail capnogram. Okay. So this is again found in neonatal ventilation, premature airway closure. You can see in this tracing, sudden upstroke, the pigtail mechanism. So it's not only given in textbooks, it's a practical scenario as well. Especially capnogram, I think is a little bit complicated when we deal with neonates and thoracic surgery. Okay, but we need to be aware of these changes. Okay, Dr. Aditya, your friend has intubated a cardiac arrest patient, and this is what you find on the monitor.
So it would depending on the value, it would show the adequacy of cardiac compressions. If compressions were ongoing, then I would try to target an EtCO2 of at least 10, but ideally 20 and above.
Sorry, patient is not in cardiac arrest. Okay, patient is in distress. It's a trauma patient. Because patient is in distress, your friend has, the trauma team has decided for ventilation for primary survey and all.
Then, so then it's probably an esophageal intubation or because since it was done in the emergency department, it's probably done in a hurry and the patient wasn't as well relaxed, or it could be a multitude of reasons, but probably an esophageal intubation.
Yeah, first thing you consider is esophageal intubation. Okay. Other possibilities are ventilator disconnection, airway obstruction, problems with the ET tube. Okay. So we had a scenario when when anesthesiologist intubated nasally, and afterwards no EtCO2 trace, and to that person's surprise could not squeeze the reservoir bag at all. So we were all confused. We did laryngoscopy. We saw the endotracheal tube passing through the vocal cord, but zero expiratory tidal volume. The bag is too tight. So what you do is when you don't get EtCO2 tracing, either the tube is in the wrong place, which was unlikely in this case. But anyway, if it is not working, remove the tube. Okay. So we removed the tube. We found that some nasal cartilage or something has completely obstructed the nasal endotracheal tube. So we removed it, did the face mask ventilation. Suddenly the ventilation was okay. So there was nothing wrong with the patient, nothing wrong with the laryngoscopy. But as long as you don't get EtCO2 tracing, don't continue with that endotracheal tube. Patient will be better off without that endotracheal tube. Okay. So this is also found in other scenarios like water droplet contamination of the capnography module, which definitely we need to be checking before the start of the first case. Apnea test in brain death patient, you get a similar scenario. And it can also, as you mentioned, lead on to or give a clue regarding cardiac or respiratory arrest. Because of cardiac arrest, no CO2 output, no EtCO2. So this is the message: absence of EtCO2 tracing should be interpreted to mean that the endotracheal tube is not working. Either it is not in the trachea, it requires replacement, no trace, wrong place. Simple. Okay. Any clue on this? Yeah, Dr. Deepak?
Sir, this is due to different patterns of ventilation in both lungs, probably near after a lung transplant.
Single lung transplant, yes. Okay. So the alveolar plateau, the mechanism you mentioned is continuous release of different alveoli emptying carbon dioxide. Now we have two different players, two different lung with different V/Q ratios. I think a similar scenario is possible when the patient is in lateral decubitus, because the V/Q ratio, the dependent lung will be different from the one non-dependent also. So these are the differential diagnosis. As I mentioned in the beginning, you don't try to interpret with the capnogram tracing alone. You need to have a history and what is the trend, the values, and then only you can interpret properly. Okay, so this is an academic exercise. So severe kyphoscoliosis, when one lung has a totally different V/Q mismatch, you get a phase 3 like this, single lung transplantation. And the waveform, sometimes some others mention as camel hump also. Okay, so this is the tracing. No points in diagnosing. Okay, quickly, somebody summarize this. Yeah, Dr. Prajwal.
Sudden hypotension, sir, or embolus wounds.
Coming to non-zero value, suddenly dropping to non-zero values, a shock.
Cardiac arrest also.
Cardiac arrest. It could be a cardiac arrest or pulmonary embolism. So if you know the history and know the trend, you can troubleshoot it better. Of course, other possibilities like breathing system disconnection or surgeon totally occluding the tracheal tube, ventilator malfunction. This is also possible. Okay. So it can also be a result of a plugged gas sampling tube, as I mentioned, water droplets suddenly occluding, which is very common. So every time, don't try to interpret with the tracing alone. So how do you comment on this? This tracing, what could be this? The shape actually, yeah, okay, Dr. Deepak.
Sir, spontaneously breathing patient.
Spontaneously breathing patient, which doesn't have any characteristics, faces that you mentioned. That means there is a sampling issue. So it could be a non-invasive device, face mask, spontaneous ventilation. I think most of the regional anesthesia these days, people use gas sampling EtCO2 port to see that the patient is breathing, which is not very reliable. That is one message. Okay, if it is there, yes, but if tracing is not there, you don't understand that the patient is apneic and jump into intubation and all. Okay, because of the sampling error. If sampling is proper, you give respect to the tracing value trend. But if sampling is in a low flow system, face mask or Venturi, even HFNC, you don't get a reliable EtCO2 monitoring. In such scenarios, what is your solution? If you want to monitor EtCO2, suppose you are using Thrive. You have used Thrive, transnasal humidified? No? Okay, for laryngeal surgeries. So you can't get a reliable EtCO2 because of this sampling issue, because it's very high flow going into the airways. If you are very particular, if you want to have a reliable PCO2, do a blood gas. Okay. If you are working in a very good infrastructure setting, you can have transcutaneous carbon dioxide monitoring, CO2 10. I'll show the picture later. Okay. So this is one scenario where you have just taken over anesthetic care of a 14-year-old girl on plastics trauma list. Monitor alarm starts to function. These are the monitor values. Who wants to take this? Yeah, Dr. Manas.
So it can be malignant hyperthermia. Because
Yes.
EtCO2 value is too high. And also tachycardia is there.
So all the corroborative evidences are there. Tachycardia is there. You can see a rise in temperature. You can see hypoxemia, hemodynamic collapse, and very high, extraordinarily high end-tidal CO2 values. Okay, it has gone much above the reference range. So this is one, I think, one routine or favorite question in some of the board exams abroad. In India, we don't probably identify malignant hyperpyrexia, but can you mention a similar scenario which we can find more easily in our country?
Thyroid storm, probably.
Hyperthermia.
Yeah. Again, you get high sympathetic drive, high EtCO2, and hemodynamic changes. Excellent. Okay, we are not going into the details of malignant hyperpyrexia and the management, but I have reserved a question for the audience because audience today are very enthusiastic. I appreciate that. Following a true concerning malignant hyperthermia. These are multiple true false questions. You can answer like true, true, false, 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 like that. Okay, first statement is it is inherited in an autosomal recessive manner. Statement B, accurate diagnosis can be made by DNA testing. Statement C, patients have usually had previous uneventful general anesthesia on diagnosis. Okay, malignant hyperthermia. Previous uneventful general anesthesia is possible. Option D, elevation of EtCO2 is one of the earliest and most sensitive specific signs of malignant hyperthermia. Generalized muscle rigidity is a late sign. So 5 statements. It's your time. Okay. I'll proceed to the previous question. I think many people have answered it very correctly. Yes. Yeah, there are people who got it right also. Congratulations. Okay, if you see the EtCO2 tracing, there is a sudden rise in EtCO2, which comes down to almost normal value a little later. So where does it happen? A transient rise in CO2 discharge from the circulation, from the respiratory system. Okay. Have you used tourniquet? Yes. Release of tourniquet or release of vascular clamp? Yeah. These are the possibilities. So once you release the tourniquet, suddenly there is a surge of metabolites. The smoke from the fire of metabolism gets emptied into the general circulation and gets exhaled through the lungs. And after some time, it goes back to them. Same happens with vascular clamping also. So now we'll switch over to Dr. Richa Tripathi for some recent advances in capnography. Over to you, Dr. Richa. Yeah, your microphone is still on mute mode. Your microphone is mute.
Okay, sorry, sir. So, thank you, sir.
Slide mode also.
Thank you, sir. Can you see this? Okay. So,
Yes.
so my seminar is on recent advances in capnography. So, as sir already pointed out, now ACLS has used capnography to ascertain the effectiveness of chest compression and duration of CPR. There is also correlation between partial pressure of end tidal carbon dioxide and cardiac output that can indicate return of spontaneous circulation. This is an American Heart Association CPR guideline. And here if we focus, there is advanced airway where endotracheal intubation is given with waveform capnography, which must be monitored. And return of spontaneous circulation is also signaled by EtCO2 tracing. Inav et al. Used mathematical modeling to predict the survival from resuscitation based on computerized continuous capnography. And these values could potentially be a tool for early real-time decision-making during resuscitation. Next, role of capnography in therapeutic hypothermia and extracorporeal life support may also be seen. A 2009 French guideline addressing indications for ECLS suggests that using a PET CO2 value of more than 10 millimeters of mercury may help in guiding towards the initiation of ECLS following out of hospital cardiac arrest. However, much more investigation is needed to help determine the role of PET CO2 during CPR to guide initiation, method, and duration of this emerging neuropredictive strategy. The AHA and Association of Anesthetists of Great Britain and Ireland have rightfully endorsed the use of capnography during CPR. However, the future of capnography in CPR will be determining the outcome based on capnography waveform PET CO2 values. Coming to the ICU, capnography can give us details about lung and circulatory physiology. It can also tell us about the impaired matching of ventilation and perfusion. It can help direct fluid responsiveness in shock patients, and volumetric capnography, which correlates with metabolic production, circulatory transport, and carbon dioxide elimination in real time. This is a picture of volumetric capnography. Capnography in ICU will show some correlation between healthy lungs and sick lungs. As we can see that partial pressure of arterial carbon dioxide is higher than EtCO2 in a normal patient, and this gap increases in patients with sicker lungs due to more dead space ventilation. So it can also help guide the target PaCO2 for intubated patients. In patients with increased intracranial pressures, we can attempt putting it towards the normal range, and we can also go for normal blood gas values in ARDS and in cases of acute exacerbation of COPD. So there are a few demography of patients that require tighter control of PaCO2, for example, in neurocritically ill patients, patients with right heart failure, and in pregnant patients. Other pathologies may also require such specific pH management strategies, for example, severe salicylate intoxications in patients undergoing alkalinization. So there are a few demography of patients who may not require such tidal control. So there we can just use the EtCO2 values to assess what the PaCO2 might be. So for patients with pulmonary disease, for example, ARDS, severe asthma, bronchopleural fistula, permissive hypercapnia may also be better, targeting a value of pH more than 7.15 or 7.10. So detection of occult hypercapnia during spontaneous breathing trials is also on the way. Hypercapnia evolving during a spontaneously breathing trial can be measured using serial blood gas measurements, but ABGs may be more invasive and inconvenient for the patients, especially the ones with no arterial blood gas cannulation there. So ETCO2 may be a more convenient and useful tool to ensure that patients are continuing to ventilate adequately. If the ETCO2 increases by 10 millimeters of mercury during the spontaneous trial, this should raise some concern about the patient may not be breathing adequately. Coming on to the other advance in capnography is transcutaneous carbon dioxide monitoring. So this is an instrument which measures. It is more useful in preterms and infants. And here we can see the method of detection of PaCO2 by the infrared sensor. Vasodilation causes increase in PaCO2 in the arterial CO2 content, which is then picked up by the heating element, and it is displayed on the monitor via the transducer. So transcutaneous monitoring is more reliable and less, ETCO2 is more reliable, but transcutaneous monitoring may be more convenient and more reliable in the patients who are breathing openly via nasal cannula and such. It can also be used in Thrive, like sir just pointed out, in laryngeal surgeries. And there are limitations of transcutaneous carbon dioxide monitoring. But however, this is a less non-invasive method, so it may come on the way. Thank you.
Thank you very much, Dr. Richa. You can stop screen share.
Yes.
Yeah. Right. So one question, like if you are taking duty, okay, you get a COPD exacerbation, you find PaCO2 of 110. So how do you set your minute ventilation in your mechanical ventilation? So what are the guidelines? So PaCO2 is above 100, say 110. So would you set a minute ventilation of 8 liters, 10 liters to bring it down to say 40 or 45? What's your strategy? Which CO2 you are targeting? Dr. Deepak?
The permissive hypercapnia is preferred here, sir. If the patient is brought down to a normal PaCO2, what will happen is the respiratory drive, which is set at a higher PaCO2, will be lost. So higher PaCO2 than normal, nearly 70 will be appropriate.
Yeah. So COPD exacerbation, everybody knows that the patient may be having a chronic respiratory acidosis. Okay. So his baseline PaCO2 is not going to be 40 or 42 or 45. So it may be 50, it may be 60, it may be 70. So my question is, how do you target your PaCO2? From 110, where do you want to bring the PaCO2 down to? Yeah, Dr. Aditya?
So we can use the patient's pH on an ABG to determine what exactly we need to target. In case the PaCO2 is elevated, we need to aim to bring the pH back to the permissive hypercapnia range. So we can calculate based on that for
exactly the message I want to deliver, because we don't assume that this patient has a PaCO2, baseline PaCO2 of 50, and I'm trying to bring it down from 110 to 50, maybe over the next 4 hours, 6 hours, or before I hand over the duty. No, you check the pH, you are actually targeting pH. If patient is in acute respiratory acidosis, wash out CO2 just to bring the pH to normal range. You don't have a PaCO2 target. Your target is going to be pH, because cellular metabolism and mitochondria respect the pH. They don't respect the PaCO2. Okay, fine. So this is the audience question response. I think 1 or 2 of our viewers have correctly mentioned about option E and option D. But for clarification, option A, statement A, it is inherited as an autosomal recessive manner is wrong, because it's inherited as an autosomal dominant condition with variable penetrance. Accurate diagnosis can be made by DNA testing is wrong, because we do in vitro contracture testing, IVCT, pharmacological testing of fresh muscle strips. Okay. Patient has a previous uneventful exposure, does not exclude malignant hyperthermia this time. Okay. Elevation of end-tidal CO2 is one of the earliest, most sensitive, specific signs of MH. Thumbs up. Generalized muscle rigidity is a late sign, so you don't wait to see that. So you get all the corroborative evidence. You're happy. So I think today our audience, I'm not going to read the names of everybody. They have been very active. Even their questions to the panelists, they have responded. The exhibition part, the shark fin appearance, everything. So thank you for your patient listening. We have not done with yet. Some more points. Relationship between EtCO2 and cardiac output. As I mentioned right in the beginning, the smoke of the metabolism, the fire, is CO2. So amount of CO2 clearance in the lungs will always be equal to the carbon dioxide production in the body in the normal state. The concentration of CO2 in exhaled gas depends only on body's CO2 production and the minute ventilation. So if the production matches minute ventilation, no accumulation. Cardiac output doesn't affect EtCO2 in a steady state. So this is one take-home message. Cardiac output doesn't affect EtCO2 in the steady state. There are exceptions, I'll tell you. Dynamic changes in cardiac output can cause transient changes in EtCO2. So let's imagine what happens if the cardiac output suddenly drops from 5 liters per minute to 3 liters per minute. Immediately, there will be a reduction in CO2 delivery to the lung. Then only it can be exhaled out. Okay. Over time, CO2 will build up in the tissues. This will increase venous blood CO2 tension. Then eventually, this will elevate the EtCO2. Okay. So after re-equilibration, drop in cardiac output would have no lasting impact on EtCO2. So initially, there is a drop which will settle after some time. And cardiopulmonary resuscitation is a perfect example for this disequilibrium state where EtCO2 is strongly driven by cardiac output. Higher the quality of CPR, higher will be the cardiac output, higher will be the EtCO2. So efficient CPR or chest compression says you get an EtCO2 well above 10, above 20 is desirable. I think one of the audience, they have asked what is the desirable. And I don't think guidelines clearly mention 10 or 20 in like that. But if you target something above 20, below 10 is definitely not acceptable. If you can achieve above 20 or in and around 20, your quality of chest compression is good enough. Return of spontaneous circulation will cause an abrupt jump in EtCO2. Dr. Deepak has already mentioned. Passive leg raising maneuver is another scenario where we can study this dynamic changes in cardiac output and EtCO2. Here you can see with passive leg raising, there is a transient increase in EtCO2. Actually, with the passive leg raising, you don't try to measure cardiac output by systolic blood pressure alone. You should have a cardiac output monitor. If you don't have, EtCO2 is one of the next best choices, which will trend like this. If you volume resuscitate, you can see as cardiac output improves, the EtCO2 also improves. Definitely, as I mentioned, in sick lung, the difference between actual arterial PCO2 and end-tidal CO2 increases. Normally, it's less than 2 to 5, but in sick lung, the difference increases. So in sick patients, you need to have intermittent blood gas values to corroborate your EtCO2 trend, which is very important. So EtCO2 is one of the monitor which can guide you in your fluid assessment of fluid responsiveness. Okay. If with the passive leg rising, if there is a transient increase in EtCO2, that means patient can take volume. Okay. So patient should be normally fluid responsive. Lack of fluid responsiveness is a pathological condition. It could be due to volume overload or cardiac dysfunction. Okay. So this is very important point. we can use passive leg rising test. Increase in EtCO2 by 5% of the original value appears to have more sensitivity, 70 to 90%, and specificity, 94 to 100% for fluid responsiveness in as mentioned in the literature. Okay, the correlation between pressure of PEtCO2 and cardiac output increase is good enough to take it as a surrogate marker. If you don't have cardiac output monitor per se, EtCO2 can help you a lot with fluid responsiveness assessment. Another thing is, if patient is not shown to be fluid responsiveness, there could be a role of de-resuscitation. ICU is not a place for resuscitation all the time. So once the healing process starts or sepsis settled down, there is a role of de-resuscitation. I think we have discussed the de-resuscitation before also. Okay, volume capnography. I think Dr. Deepak has initially introduced it. Because of lack of time, I don't think we should be going much into the details of it. Basically, volume is plotted against the carbon dioxide concentration. Here you can see. And once you get a plot, you get different areas designating different parameters. Say here, the white area, the area under the curve represents expired volume of CO2. The yellowish shown area is alveolar dead space, and Z is airway dead space. Again, there are different theories and calculations determining the airway dead space and physiological dead space. And most of the newer ventilators, actually, they give the capability to predict the physiological dead space and determining the pathology. That will give better clues to the pathology, what we are dealing with in an ICU setup. So the ventilators are becoming more equipped. So we need to learn this volumetric capnography, especially if you are handling ICU patients with the ventilator, giving you this facility as well. Before we end, a few words about oxygraphy. So far, we have been trying to discuss CO2 percentage against time. Now I'm trying to tell oxygen percentage against time. That is oxygraphy. In most of our monitors available in our place, you can have you have gas analyzer. So the monitor should have the capability to put the tracing of oxygen percentage against time. This is one article appeared in as early as 2009. If you look at this tracing, see here is the capnogram tracing. This is spontaneously breathing patient. This is say pre-oxygenation time. Down here is the oxygraphy tracing, where percentage of oxygen is given. Here you can find the inspired concentration is 100 throughout, and end tidal oxygen is gradually increasing. And when it touches 90, that means your pre-oxygenation is adequate. But I'm not sure all patients we can pre-oxygenate to this level. End tidal oxygen to 90% is a tedious task, especially in the extremes of age, obesity, and emphysema. But this is one modality which can help you with that. Second use they have mentioned is in the presence of a mechanical obstruction, kinged ET2. You can see the capnography tracing on top and oxygraphy tracing on bottom. Oxygraphy tracing seems to be more sensitive to display the change due to the mechanical obstruction. Here, another thing we have discussed about the curare cleft. Here you can see on the A part of diagram, the phase 3 looks straight. EtCO2 looks almost straight, but the corresponding oxygraphy shows a cleft which is equivalent to curare cleft. Here, once the curare cleft becomes obvious in the EtCO2, oxygraphy, it has shown much before that. So oxygraphy is something that you can try out in your monitors. You can see, you can put the oxygraphy tracing. It will something like a mirror image of EtCO2. Because during inspiration, oxygen level increases, exhalation level decreases. Usually the difference between inspired and exhaled concentration will be less than 5. And some others believe that when the patient becomes in a lighter plane, oxygen extraction increases and the difference between inspired and exhaled concentration also increases. So I think that there is a scope for continuous interest in oxygraphy also, but I am not sure how much the literature supports the utility of it in the perioperative settings. So I think we can today's session now. I think we should congratulate all the PG panelists and of course the audience. I think there are different encouraging remarks, the answers to our scenarios, comments to your performance. So many people, I understand, have enjoyed the interaction describing the ETCO2 scenarios, capnography scenarios. I think it may not be a whole exhaustive discussion. We might have missed out many things. I agree that we have missed out the capnography in terms of some extremes of age groups like neonates, neonatal ventilation, thoracic surgery, lung isolation. Then it will be too much exhaustive. And some of them are beyond the scope of my capability also. Okay. So I think we can wind up now. From PG panelists, if you want to give your closing remarks, you can do it before we proceed to the vote of thanks, formal vote of thanks part. Dr. Deepak?
So thank you so much for this opportunity. It is not every day that you get to share such a platform with PGs from all different institutions. Like most of these institutions, I have only known while filling for my PG like allotment list and all. So thank you so much for allowing me to be a part of this, and thank you for the wonderful.
We are more integrated. We are more collaborating. Correct, Dr. Aditya?
Yes. Yes.
Okay. So anybody else would like to comment on this? Any suggestions for improvement? You can let me know through email also, through my WhatsApp also. I think it's time to wind up and hand over the podium to Beljit Singh sir for distribution of e-certificate of appreciation from Indian College of Anesthesia to all the youngsters, the PG panelists who had a great impact in today's session. Over to you, sir.
Thank you so much, Dr. Saneesh. I think it was an excellent program. The last, about 2 hours or quarter to 2 hours have been just spellbinding. With regard to the postgraduate participation, I think they have done so very well. Whether they were, it was in the interaction part of it when you were describing the case scenarios. So you have congratulated all of them. Congratulations to me from my side also. But I think I would like to congratulate you first for having brought out the best in the students. That's one. Not only that you brought out the best in the students, you did so very well. You structured the class in such a manner that after the initial introduction of the basics and physics by Dr. Deepak, then you put up the scenarios to discuss threadbare. So each and every point was so very well explained, whether they are the angles or whether the plateau or, there are so many aspects. I can't name each and every aspect of that. So it was an excellent academic session that we have had, and I think I'm so very pleased to present the certificates to all these the postgraduate students. Should I speak the names? Dr. Manas Omer from King George, Lucknow. Over to you, Dr.
Thank you, sir.
Look forward to seeing you more in the ICA programs. Dr. Shreekara, congratulations.
Thank you, sir. Thank you, sir.
And Dr. P. Deepak, the beginner, the person who started the discussion and laid a very strong foundation for the further deliberations on the topic.
Thank you, sir. Thank you, sir.
Dr. Prajwal Siddappa, contribution of all the participants in this program was excellent, and so was Dr. Prajwal. Thank you so much, Dr. Prajwal, and Dr. Vrinda KV.
Thank you, sir.
And I think we are left with Dr. Aditya, Karanth, Uchila from Maulana Azad, New Delhi, and
Thank you, sir.
Richa Mani, excellent presentation from each one of you. You explained the things so very well. You, I think, matched what Dr. Saneesh wanted to get out of you. So compliments once again, and we look forward to having your participation more and more times at this platform. This class, I believe, would be extremely useful to all the postgraduate students because the details that have been discussed, shows how much you know about capnograph. And describing it, normally the terms capnography, capnogram, all these terms are sometimes used interchangeably, which is not the case. And this was very well described right in the beginning itself. So capnography, when I was a student, not much attention was paid to it. And in the last few years, it has more and more applications, whether it is even in advanced cardiac life support, protocols, the guidelines, this as I mentioned, or it is the fluid responsiveness, and so many things that we have brought out. And I believe there will be, in the coming few years, there will be even more applications of this. It's an excellent tool. And so beautifully it describes that this is a smoke, from the fire of metabolism. So, friends, my compliments to all. Of course, congratulations to Dr. Saneesh for the excellent program that he has conducted, moderated, and all the participants who have so beautifully participated in that and gave their best. Look forward to you seeing you all again on the platform. And till we meet again, stay happy, stay healthy, and look forward to meeting you again in the next webinar on Wednesday next week.
Thank you very much. Thank you.
And good night.
Good night, sir.
Thank you so much to all of you, and with all your permission, I'm closing the session here for today and looking forward to hosting you again. Thank you so much, sir.
Thank you, Mamita.
Okay,
for
sir.
being
Thank you.
with
Good
us.
night.
Thank you so much.
Thank you, everybody.
Nice.
Saneesh
Thank you.
and
Thank you.
participating panelists and all the audience. This was an excellent webinar.
Absolutely. No
Please
doubt.
bring out this sort of webinars more often. Thank you very much.
Thank you.
Thank
Good
you.
night.
Good night.